Right. Hello, everyone. We're going to get started in just 1 second while we get set up and give everybody just a few minutes to get into the webinar and settle. Great. All right, well, I will go ahead and kick it off. My name is Jen Elder. I'm the director of the SAMHSA Homeless and Housing Resource Center, and so excited that you're joining us today for our webinar, Supporting the Mental Health and Treatment Needs of Individuals Experiencing Homelessness During COVID-19. All right. HHRC is funded by the Substance Abuse and Mental Health Services Administration, but the views and opinions shared today are not necessarily representative of SAMHSA or the U.S. Department of Health and Human Services. A couple of housekeeping items today before we get started. As I think you've noticed, we have arranged for ASL interpretation services and are so pleased that Kip and Jennifer are joining us today. Live transcription from Zoom is also available. You can click and drag the subtitles to best meet your needs. If you're experiencing any technical difficulties, you can reach out to us via email at info@hhrctraining.org. We are so thrilled to be joined. I keep seeing more and more people log in. So we have almost 2,000 people in the room already. So as a result, all participant lines will be muted. And for those who couldn't join us for the live event, a recording is going to be available on the HHRC website shortly. Now, for those who might want to go ahead and take a look at the slides and follow along, those are available now on our website, hhrctraining.org. You can see a copy of the slides. We have a supplemental resource guide and the presenter bios as well. Please submit your questions to us using the Q&A feature. We hope to get to as many questions as we can. By the end of the webinar, we'll be doing a Q&A section at the end. Then after the webinar, Zoom should redirect you to a short evaluation. We'll also have the link available for you, and that'll be provided by email as well. We appreciate you taking the time to complete that. Let us know what you thought and the training topics you'd like to see in the future. Everyone who completes that short evaluation will also get a certificate of participation. We don't have any CEUs that are offered, but that certificate is yours to keep. And so we do have the learning objectives available for those who might be submitting CEUs to your licensing board. So today we're going to dive deep into the impact of the COVID-19 pandemic on the behavioral health needs of individuals experiencing or at risk of homelessness. And we're going to hear from two programs about how they have innovated and adapted their systems to continue to provide services over this past year. And lastly, we're also going to talk through, the additional stress that we are experiencing as service providers and hear from Laura Leone about the self-care techniques that we can incorporate into our practices. A huge, huge thanks to all of our panelists for dedicating their time to share their expertise and resources to the HHRC community. Their full bios are available on the website, but just hope you take a look at it. Just really impressed by the group that we could assemble today. So Kevin James is going to kick off the webinar. He's with HHRC and going to talk through some ground setting as we get started. And then Dave Iverson is the Director of Psychiatry at the Colorado Coalition for the Homeless in Denver, Colorado. and he's going to talk through, how they've adapted their program to continue to provide in-person services this past year. We also have Ewa Enrique, the Blackburn Medical Director, and Walter Bailey, peer counselor at the Amani Center from Central City Concern in Portland, Oregon. And they're going to have a great conversation about how they've adapted their engagement strategies, technology, staff support as part of their services. Then, as I mentioned, we are going to hear from Laura Leone from the National Council for Behavioral Health about wellness and resilience strategies for service providers. So, as we get started, I'm going to pull up a quick poll question just to take a temperature check of all of us today. So you should see the poll on your end. Have you or anyone you know experienced any adverse behavioral health symptoms due to COVID-19? And I do want to say the survey is completely anonymous. Zoom does not tell us how you answered. I'm going to keep it open for just another few seconds. It looks like we have over half participating already. All right, about 5 more seconds. 4, 3, 2, and 1. We'll end the polling here. Thank you for those who voted. We got most of the group. Really interesting. All right, I believe I'm sharing the results. 68% of you said that you have experienced or you know somebody who's had adverse behavioral health symptoms due to the pandemic. And I think that's a really important statistic as we open up this webinar and talk through collectively what we've been experiencing this past year, keeping that in mind. All right. And make sure that's out of the way. So for now, I am going to pass it over to Kevin James from HHRC to get us started. Kevin?
Yes, thank you for that introduction, Jen. As previously stated, I'm Kevin James, the Project Associate for HHRC. And I just wanted to take a quick second to discuss where we've been in the last year and the impact of those events on our well-being, most specifically on our mental health and substance use. Around this time last year, there was a general sense of anxiety as to what our lives would look like in the coming months. We asked ourselves and discussed with others, will I have a job? What if I contract COVID? Will the grocery stores be open? And where's the toilet paper? We literally were scrambling to get our lives in order. Shortly after the CDC mandated certain COVID-19 activities such as social distancing, isolation, and quarantine. But while America's public health became priority, we simultaneously rode into a period of traumatic events after another. Black America grieved the loss of their brothers and sisters due to police brutality and violence, as well as being disproportionately impacted by COVID-19 related deaths and hospitalizations. But our trauma didn't stop with racial injustices. Americans living in coastal regions of our country experienced one of the most active tropical storm seasons in history. Our neighbors in Louisiana experienced a record 5 storms making landfall. Our neighbors in California experienced record-setting forest fires in 2020. A few weeks ago, the southern part of the United States was impacted by a winter storm that left us without power and clean sources of water. So accounting for these events, we collectively have shared grief and can relate to another like never before. And how have we reacted to that grief? Next slide. Here's what we know. We know people will find ways to cope, whether that's with a pandemic or grief in itself. We know any of the events mentioned in the previous slide is traumatic within themselves, but compounded with the pandemic, things only get worse. And it's important that we all understand that we are not alone. The adverse impact of COVID-19 on our mental health, substance use, and emotional well-being has been documented by researchers. The slide you see in front of you shows findings and themes from 3 reports. One from the Center for Disease Control and Prevention's Morbidity and Mortality Weekly Report, a report from the American Psychological Association, and one from Mental Health America. And while we won't be able to provide you with every statistic on this slide, We will provide you some key findings and include supplemental resources on our website. Bullet number 1 talks about understanding the pandemic's impact on anxiety and depressive disorders. Often, when we mention increases in adverse mental health symptoms, some may find it hard to understand because they found ways to cope. But findings from the CDC's MMWR include 41% of respondents to their survey reported having adverse mental health symptoms related to COVID-19. Based solely on that information alone, one could only imagine the change in demand for treatment services on our providers. But while the impact of the pandemic is reflective across all populations, the mental and behavioral health in communities of color, youth ages 11 to 17 years old, and young adults ages 18 to 24 have been disproportionately impacted during COVID-19. And I just wanted to touch on one of the statistics that stood out to me the most, and that was over half of youth reported having suicidal ideations or thoughts of self-harm more than half or nearly every day leading up to completing a screening. Most specifically, youth that identified as LGBTQIA+ reported having suicidal ideations at a higher rate than others from their age group. In terms of communities of color, Black and Hispanic populations reported a higher percentage of individuals seriously considering suicide. And there's a lot of factors that could have contributed to this, but we all know with guidance for isolation and quarantine, we all lost a sense of community and socialization, which has directly impacted our sense of well-being as well as connectedness. Lastly, the pandemic's impact on substance use is not unnoticed as well. Findings show that there is a reported increase in individuals who began or increased their substance use during the pandemic. Next slide. And while we've done a great job finding ways to be creative and providing services over the last year, now more than ever, treatment and prevention strategies are needed to instill hope and encourage our participants as well as ourselves. So before passing it over to our first presenter, one thing I wanted us all to remember is that there is hope. There's hope that we can expand access to care through telehealth and other treatment modalities. There's hope that we can unify and encourage other members of our community. There's hope that we can strive to be culturally and linguistically competent to tailor services for all ethnic and cultural groups. And there's hope that we can be an ally for Black, Indigenous, and people of color, persons with a behavioral health disorder, and other participants that we serve. So as hope has it, I would like to leave you with my favorite quote by Dr. Martin Luther King Jr., and that is, "The time is always right to do right." Thank you for allowing me this opportunity to share this information with you today. And I just wanted to introduce you to our first presenter, Dr. Dave Iverson from Colorado's Coalition for the Homeless, who will share ways with you that they've been creative during the pandemic to expand care, amongst other things. Thank you.
Hope everyone can hear me. I'm Dave Iverson, as Kevin just mentioned. Kevin, thank you for everything you just said. I am the psychiatric director for the Colorado Coalition for the Homeless. And let me get the technology in order here. There we go. CCH is a housing development, management, and healthcare organization for people who are homeless. Our behavioral health services are primarily based at our main clinic, the Stout Street Health Center, and also with a scattering of Housing First programs throughout our organization. We reach throughout the metro area of Denver and then have outreach efforts throughout the state as well. At the Stout Street Health Center, we use an integrated health model where the behavioral health, medical teams, nursing, peer support specialists, dental, and even an in-house pharmacy all work together in the moment, every moment for our clients every day. And we're thrilled at that sort of model and the advantages that it gives. So for the next 19 minutes, I'm going to give you a virtual tour of what we have done in our behavioral health programs to face this pandemic. Here is Robert Frost. Do you remember the disbelief as this pandemic took hold? It's a distant memory already. It is a lonely business, I think. I've always felt that way as a provider of support to people who are homeless, because I think too often society is basically disinterested, and people who are homeless can essentially feel invisible. And this is something we combat every day. Now, as the pandemic was taking hold, of course, virtually the entire world was planning to shelter in place at home and work the phones. Now, of course, that wasn't going to be possible for people who are homeless and in large part don't have phones. So we had to grapple with that immediately right off the bat. This is a shot of our Denver rescue mission, the line at night. This is a picture from the Denver Post. So we recognize that this was really a crisis times three. Trying to get housing for people who do not have housing is tough enough. Getting services for people with serious and persistent mental illness, even tougher. Then doing all that on top with a pandemic added on top of it, it really set the stage for a new path, so to speak. So much was unknown at the beginning, and we had no choice, of course, but to find a way forward. We recognized that we needed to stay open, not just for the sake of our homeless clients that have no homes and have no phones, but also to work this pandemic. That line outside the Denver Rescue Mission, those lines have persisted. Maybe there's better spacing and there's some masks, but we knew that to avoid an explosive outbreak within these folks in our community, we needed to virtually, literally work this pandemic and help people space out and find a safe way to move forward. The equipment came in, and here are some of the initial triage tents. That's Dr. Ed Farrell, my compatriot over on the medical side, the medical director. He was quite as excited, as you can see. And Andy Grimm, our operations vice president, literally combed the earth, ordering internationally to get us all the PPE that we needed. Thankfully, this amount of spacing, getting a waiting area set up in our parking garage, it never came to that, but we were ready to do it. This parking garage is kind of depressing, kind of dark. So, we had to evolve as we went and make it up as we went as well. The most important step we took immediately was to adopt an incident command structure. And our safety director, Peter Dybing, formerly worked for FEMA and was part of the Katrina effort down in New Orleans. So he had some comfort with this. Many of us, including myself, had some experience in the past with the VA. So we were also familiar with this sort of model. So branch directors were installed for mental health, medical, logistics, et cetera. We set the priorities, with safety being the top priority, and grappled with the evolving legalities and ethics as we all scramble to try to figure out how to move forward. We created daily check-in and check-out meetings, and those had been invaluable. We've tapered off the frequency of those, but how it enhanced our communications, and even to the point where our auxiliary housing that we've created for COVID, there's a newsletter that goes out throughout the agency on a weekly basis on what's happening with that endeavor. So staff expansions happened, thankfully, with additional FEMA funds. And on the right are some of the ideas we had just initially to frame our approach. And I thought for an infectious disease global emergency, BH was going to be in more of a supporting role, but that's not true anymore. As Kevin mentioned, with the grief setting in, the losses, the stress, the fatigue, the depression, the anxiety, the addiction, we've really become certainly much more primary. Now, that quote that more people died of not Ebola than Ebola comes from one of our main allies at the city, the top public health officer for the city, Dr. Bill Berman. And he pointed out that in that epidemic, more people died of other chronic illnesses than the viral agent itself. That helped us focus where, of course, we had to keep the ball on the pandemic itself, on the COVID virus, but also not neglect all those clients that were otherwise still affected and suffering from depression, addiction, what have you. And that's helped us, I think, keep our wits about us as we've gone forward and stay flexible, caring for our clients and for ourselves. And off we went. Here's a triage point at one point. These are a couple of our nursing staff. And I should mention that for an integrated behavioral health team, we're blessed really with behavioral health providers, social workers, LPCs, psychology, psychiatric nurses, MAT teams, psychiatrists providing the medications, obviously focusing on that, peer support specialists. And besides the daily clinic work we do, and we have continued to do during the pandemic, as I mentioned, we really do quite a bit of crisis work. So we're really a half-time mental health center among the integrated care and all the other disciplines that are happening, and an urgent care center as well. We dove into telehealth immediately. As it turns out, many of our clients do have phones, and they recognize the imperative of avoiding crowds and avoiding the crowded shelters and staying where they were if they could. So it not only benefited our clients, but it benefited our staff as well. Those that were over 60 stayed home, and those with medical conditions that might put them at higher risk of succumbing to COVID also were able to stay home but still serve. So it's been such an important tool, and I'll talk more about that in just a few moments. This is just a partial list of our partners. And whereas before, the shelter routine in the Denver metro area has been out at 5 a.m. and then you're on your own, you're on the streets, and then return in the evening to stand in line and hopefully get a bed. That got translated into something much better, 24/7 coverage, where folks could hopefully not commingle so much, stay where they can during this awful crisis, and then thereby help diminish the spread. So this gave us enhanced access to our clients, an ability to help them more comprehensively day after day and be with them more extensively throughout the day, and better access to our partners. And those partnerships have been enhanced, and that has really been a silver lining that's going to persist. One of the most important steps initially then was to commandeer the National Western Stock Show location, which under the underpass there is adjoined with the Denver Coliseum. So these are immense spaces. And whereas the Denver Rescue Mission, for example, is a shelter that was quite congested and was feared to really be a potential for an explosive outbreak of COVID, this was a much better alternative. So what you're seeing, believe it or not, are 700 cots that had better spacing than what we had previously at these shelters. So we went forward on that. Now, we had to have a clinical element, and that's where we came in for the Coalition for the Homeless and our integrated teams. So where else but, a tavern and bar and grill. So within 24 hours, our logistical team, and here's Tunisia and some of our medical staff, got this set up. The supplies came in, the exam rooms were created, stalls, I should say, but they served the purpose. And right behind that curtain the whole time was the bar, which thankfully stayed closed. And here's Paula showing off our slightly out of the way, more quiet, a little more private interview space for our behavioral health team. So this was a busy clinic while this National Western Complex was utilized. You can see the smiles here behind the masks. It eventually got broken down, but the Coliseum persists with about 300 beds over there. And we had a Zamboni. How many clinics get a Zamboni? That was a great benefit, I thought. All you hockey fans will understand that. I didn't get to drive it, and I'm still sad about that. Maybe someday. The next important thing we did with our partners, the city, and with funding from FEMA, was to commandeer 7 motels and hotels around the Denver metro area for what we call protective action and then activated respite, which I'll show you in a moment. These protective action sites, so-called, were used to isolate people who were more at risk for COVID older people who were homeless, and also those with multiple comorbidities, medically, pulmonary conditions, where they could be out of the fray, out of the crowds, out of harm's way, and better protected from the virus. So medications are delivered. This is still ongoing, of course. Methadone, so our SUD programs and MAT operation can continue. Food is delivered from the Salvation Army and other partners, and this has helped. Bullpen areas, workstations for the integrated teams are at each site. And it was interesting that our medical teams, I think, didn't really know the extent of the serious symptoms of severe mental illness or addiction that our clients suffer from over a 24/7 experience. We knew that in mental health, but they didn't. So I'm glad that they grasped that. This is La Quinta, a hotel just north and west of the downtown ballpark in Denver. So this was our activated respite site. And this has been reserved for COVID positive clients and so-called PUIs, persons under investigation. So everybody working here is in PPE at all times. And for those people who are homeless, who are COVID positive or having symptoms and we're waiting for their test to come back, they can isolate here. Now you could imagine, we know what isolation does to people suffering from mental illnesses, to everybody, really. It's tough. So the staff has been doing everything they can, providing support, therapy, counseling, crisis management, getting even cigarettes to the clients to help people endure the isolation and successfully stay in place as they're waiting for their symptoms to pass. Length of stay there has been about 9 days on average. And up till today, we've had about 2,200 screenings and placements because of this effort. The goal, of course, has been to flatten the curve. And we're gratified that in the Denver metro area, the COVID numbers among our clients who are homeless has stayed largely at or below that of the general population. So that is hopeful, I think. Here are some of those numbers. And on the left, these are some of our year in and year out numbers, which I won't belabor. But on the right are some of the numbers I've been sharing with you over the last couple moments. At this activated respite site, we've sometimes doubled people up when there's been surges in either symptoms or in testing, frankly, and gone as high as a 155 census. So how has it gone? Well, it's been not easy. I think you know that. This is a napkin, believe it or not. This was left to me by my predecessor, and I appreciated it. She thought it would come in handy, and it has. But no, we've done much better than this, and people have done, I think, remarkably well. And anxiety is, I've always thought, is an infectious disease. So our goal as mental health providers, and for the sake of our clients, and really they help us in many ways too, they can teach us so much, but the goal has been to keep it together, stick together, get through this together, and do everything we can through resilience. Now, as Jen and Kevin told you, Laura's going to be focusing on resilience shortly, so I won't belabor this, but I do want to share this one slide because we've really used these sorts of ideas. This comes from Southwick and Charney. And to face our fears, I mean, early on, I really did think, well, this thing might kill me. And, are we okay with that? Well, no, but you go forward anyway. You stay optimistic, but realistic. Use our supports. Keep our morality, our moral compass, our spirituality, the meaning that we have in life and in our work, accept what we can't, stay fit, and then seek growth through this endeavor. And it's possible. We have to be realistic about what we're facing. Now, here's the enemy, we could say, but I see it more as the natural balancing of nature, and more as an adversary and antagonist to overcome. We also have to be students of history. We've had pandemics throughout human history, of course. So even though the death has been unbearable, humankind can endure. So this has helped us, I think, stay centered and stay focused. Resilience helps us strengthen emotionally and have the sort of fortitude to smile ultimately in time, despite the trauma and despite the sometimes what feels like unremitting stress. Hope is something we have to cling to. We have to. And as the mental health professionals and the so-called experts on the emotional world, I think we've been leaders, not just helpful to our clients, but also supportive to our colleagues. I think we've been able to maintain balance as we do this work, hold each other accountable. I, for one, have really gotten into mindfulness for the first time ever. I think I was resistant before, and I found out that it works now, and I recommend it. Death is one of those emotional subjects that has been chronically neglected. And in medical school, when I was there, it was undertaught. I think that's getting better. But ironically, death is always hovering over our clients who are homeless. A psychiatrist wrote in a periodical I saw recently that existential threats are nothing new to people who are experiencing homelessness. So this has been something, of course, we have to endure and grapple with and overcome. But frankly, we're used to it. Grief is different. And we've had to support our colleagues for that and find new ways to grieve when grief is delayed or deferred. My favorite quote was passed to me by a colleague, and it says now, and I'm holding on to it lately, those that we've loved and lost are no longer where they were, but they are where we are. And that's helping me move on. But it's been an incredible burden with quite a bit of exhaustion. But as I say, I've ridden herd over our teams and all of our managers, and again, holding each other accountable to say, when do you get time off? Take it. I've got some next week, just in time. George Floyd was killed in May of last year, as you know, and as Kevin referenced. Head of the Urban League pointed out that racism is a pandemic within a pandemic and will tear this country apart. We've known this as supporters and helpers of people who are experiencing homelessness. Ironically, the healthcare inequities, the poor outcomes that reflect systemic racism, the injustice, the barriers, and the bias have been with us all along. We've known that we must do better as a country, and the time is now. And this is going to require systemic change across all areas for the sake of all of us, ultimately. We have a director of EID, Equity, Inclusion, and Diversity, Chantel Lewis, and she's been a presence not just in our agency being a leader, but across the metro area. We're quite proud of her. So, no more talk. We've had enough words. We need actual progress, actual change. We have allies. This is our chief of police, Payson, for the Denver PD. It was great to see him out front for the BLM marches last year, and we will get there. We have to. We have no choice. To shift gears, our outreach efforts have continued, and we got an exciting jolt from a statewide grant that gave us mobile tech capabilities with backpacks for telemedicine. And our Housing First nurses have made use of this in a nice way. And we're still working out the logistics, but it's quite exciting. And I think it's going to really help us get to people where we need to get to them and increase our flexibility and our access. The pluses and minuses for telehealth, I won't belabor in the interest of time, but you can read about this elsewhere. Besides the protective factors that I've already mentioned, it's lowered our no-show rate, given us better flexibility to reach people, and I think really change the intimacy of mental health encounters, where some clients like it, some clients prefer the in-person one-on-one. To wrap up, what's it mean for our country? How should we feel about all this? Where are we going? Well, this statue is a clue. We have to do better. The images I've showed you and what you see in your own cities, they should disturb you, and I know that they do when you think about it. This is not okay. And it can't be ignored. And we must do better for the sake of our fellow human beings. We need change, and we need it to be real. So I invite you to join us in our advocacy efforts. With pandemic or not, it's going to continue. We're excited about the new and innovative ways we've been able to help people and protect people during this endeavor. But frankly, the basics, getting people what they basically need, is still our challenge. So thank you for your attention, and enjoy the rest of the webinar.
Great. Thank you so much, Dave, for sharing that with us. Just as a reminder, we'll have some time for questions and answers at the end, so keep those questions coming. But now I want to turn it over to Eowyn Riki and Walter Bailey from Central City Concern in Portland, Oregon.
Thank you so much. It is such a pleasure to be here. My name is Eowyn Riki. I use she, her pronouns. I am a primary care provider and an addictions medicine specialist, and the medical director at Central City Concern's Blackburn Center, which opened in July 2019. We offer on-site primary care, specialty mental health services, specialty substance use services, housing, respite care, and employment services. And I was involved in the design, development, and implementation of the services at the Blackburn Center since 2017. As a medical provider, I work with our substance use program and our program that integrates Suboxone and other medications for opioid use disorder into primary care. We provide low barrier, easy access services to people with from intake to prescription of 2 to 3 hours for a Suboxone prescription. And we're very pleased to welcome people, especially during this time when we know substance use and overdoses have increased. I'm joined by Walter Bailey from Central City Concern's Imani program, a culturally specific program for Black and African American people in Portland, Oregon. Walter will now introduce himself, describe the Imani program, and walk us through some photos of the location of the Imani Center. Walter?
Hey, thanks, Eowyn. Walter Bailey, peer counselor, Imani Center, here in Portland, Oregon. I don't know if the slides are going to appear, but the Imani Center, we are actually a clinic. Technically, we opened in 2015, servicing African Americans with mental health challenges and issues, as well as substance use issues. This is a slide, and this is some of our artifacts that we had donated from a very, very great person by the name of Dave from Dave's Killer Bread. These artifacts are from Africa. This is in our front lobby. This is our front desk manager. Her name is Lynetta Garner, and she does a fantastic job getting our clients in, getting them taken care of and set up for appointments. Also, this is the front entrance where you can see several different pieces of art that Dave was able to donate to the Imani Center. I'm not sure how much money a lot of this is worth, but it was very, very expensive from what I heard, all the pieces that he donated to our program. Engagement. For us, I think a big thing for our African Americans is being able to utilize the services that are available. Us being an intensive outpatient model for Central City Concern and being the first of its kind, engagement is huge. And how do we go about the engagement process? Referral sources, also word of mouth has been really big for us. And so for us, it's just been one of these opportunities that we are, a small program, but we make a lot of noise because we try to do the best that we can.
And as Walter and I were preparing for this presentation, we realized that not only did we want to centralize the experience of our Black and African American clients and staff and a program specially designed to serve them, we also wanted to centralize the voice of African Americans in our presentation. And so we are going to do a question and answer format rather than a more formal format with slides. We also figured we have all had enough PowerPoint slides for a lifetime in the last year. So Walter, early on, I'd love to hear about COVID has impacted your clients' engagement and what your program staff did to reach out to clients. For many of our programs, clients fell off and fell out of care, and we had trouble reaching them. Throughout Central City Concern, we have many different mental health and substance use programs, and we have assertive community treatment teams, and they were able to maintain contact with clients because they already had contact information. They already knew where they lived. They already conducted outreach. So it was easier for them to continue that, although it was also more difficult because they were going into people's homes. One of the ways they managed that is by trading off days. So they would alternate days in the office or days working from home and days doing outreach. And by doing that, it allowed staff to have some time in which they weren't actively working in the community. We also had sufficient PPE. We were blessed with enough PPE that we were able to do that outreach. I'm curious to hear about the challenges and successes that you had at Amani in connecting with clients and how they responded to your efforts to connect.
Great question, thanks. For us early on, when we knew that this was before the actual pandemic, we started getting we started hearing this information about this deadly virus. And I have to say, for a lot of us, and particularly the staff, we were like, oh, this is just going to pass through in a week or two. But it progressively got worse. And so what happened is before we knew it, we still had a few groups within the first 2 weeks. And then we started to get the information from our executive team that this is serious. This is a deadly virus. And what happened was, for us as a staff, we had to, we were basically given permission to be off of work. And so from that, it was like, well, why are we off of work? And then we had to do our own research. And what we found was, how do we connect with our clients to let them know, like, hey, this is serious. So what we had to do was collectively go in and meet as a team. We had to educate ourselves. And the first order of business was, how can we stabilize and how can we get information that's not going to be overbearing to our clients? So the success early on was for our clients that were what we call in clean and sober housing. They had the benefit because they were protected. But we also know that the ones that did not have clean and sober housing, that were living on the streets, those are the ones that fell off. And so it was really hard. So it was kind of like the success that we had is engaging the clients that we could, but the other ones that were new or the ones that were homeless trying to still come and get their services, those are the ones that fell off. So that was really hard for us.
And Walter, were you able to get any telephones to people? How did you establish contact with those folks that you wouldn't necessarily be able to track down in their housing?
For one of the things that we did, we wound up meeting twice a week. And thank goodness for Multnomah County, as well as some other grants that came in. What we did, because a lot of our clients did not have access to phones, right? So we don't, since it's a smaller program, we did receive several blessings of donations, and then actually allocated money that we could buy smartphones. And so we were able to monitor the clients that did not have the technology or phones, and we were able to get them phones so they could have a way of communication so we could contact them. And that was very, very helpful. But it was a process. It didn't just happen overnight. So it was a gradual process, but we rallied around each other, having to educate ourselves and understand, for this pandemic and this COVID-19 as it hit, we had to understand, educate ourselves, but how do we get information to our clients to not let them know that this is going to make a big difference, and not wanting them to panic, but for them to trust us. So that was it was an interesting time. It was a challenge.
And in some of our other programs across Central City Concern, for example, in our housing, we set up booths in which people could connect with the provider by video or by phone. So if people even in housing didn't have a phone, they could have access to technologically facilitated visits through that kind of multimedia booth. Another thing that we did at some of our sites is we allowed people to come in and participate in visits in a telehealth suite, in a room in which we connected them with the provider or connected them with a group, so they could come and attend their groups by coming into the office and being in a room. So there are a lot of different ways that we tried to leverage technology. And Walter, how did your clients respond when you reached out to them? What was their response to you all working to connect with them?
For us, the technology piece, as we got further along of understanding, like, okay, this is the pandemic. educating ourselves. Our biggest order of business was allowing the space to have the clients, first of all, being able to access services. But accessing services meant that for myself personally, being a peer and a counselor, I did extra work, making sure to call as many clients as I could to educate them from the protocols of PPE, how are you keeping yourself safe, and those types of things. So early on in the beginning, I think a big thing for us is getting that technology. It wasn't a perfect science, but us calling really helped out in the beginning. Phone calls were very essential because it did take us a lot of time before we could actually start doing services again. But that was also too a big credit for our executive team at Central City Concern. They were giving us updates and giving us an opportunity to move in a manner of giving us basic orders of how we can educate ourselves, but how we can move forward safely. And that was awesome for us.
Well, and I think that's it's a lovely example of the marriage between what we think of as physical health and mental health, because you all were ambassadors for physical health by reminding people how they could protect themselves. So I think that that's a beautiful example of integration. And another thing that I remember you telling me in one of our previous conversations is how incredibly grateful people were. The fact that they felt like you were caring for them, that you were there, you were tracking them down, you were taking the time and effort in the midst of all of this literal pandemic stress, that in some ways strengthened connections with people in the middle of what otherwise could have been really challenging, what was really challenging.
Yeah, so I just have to be totally transparent. It really helped us. Learning on the fly, this pandemic, I mean, it was devastating. But what it allowed us an opportunity is the clients not only were able to reach back to us, but it made us stronger in the sense with the actual clients that we had at that particular time, of letting them know, like, this is collectively something that we're going to do together. You guys are not going through this alone. We're doing it together. And it did strengthen our core. It strengthened our relationships, and just the power of the phone, the power of connection. That's big for us. And as we moved forward, not only did that strengthen us, but it allowed us to build trust with our clients. And then the ones that we weren't able to contact immediately, the ones still, even homeless that kind of stayed around, the ones that stayed around, we were able to still connect with them. Our peer services, our other peer that we have, Richard was out doing outreach, still connecting with people. And so those few that were without technology, we were able to reach them. And then before you know it, they had some technology. And so we were still able to reach those that we couldn't reach before.
I would love to talk about the care model. It's been really interesting to watch the way literally the model of care has changed in our substance use programs. Before COVID, we were almost exclusively based on groups. And then groups became impossible because we couldn't gather. We pivoted to one-to-one counseling by phone initially, and then eventually to video groups. And then a few months ago, we restarted our in-person groups with really careful attention to spacing and face mask use. And one of the biggest debates was about coffee, because coffee had always been a really big part of our groups. And we had to have conversations about whether or not we could offer coffee in our groups. And we eventually decided we couldn't because of the risk. But that was a very practical example of conversations we had to have. In our medications for opioid use program, in which we prescribe Suboxone and other medications, we reduced the frequency of visits and urine drug screening, and we prescribed for longer periods of time because we didn't want people to have to come into the office. We didn't want them to have to physically travel or be physically in our office. We were trying to reduce the number of people in our physical space. I'm curious to hear about the care model changed at the Amani Center.
Yes, our model changed drastically. We were very comfortable with our services of in-person groups, as well as in-person one-on-ones. COVID hit, and it took us a while. I mean, I want to say it was like at least 60 to 90 days before we actually considered doing groups, which we didn't even know how to do with the technology. So something that we know for the Imani Center, we are considered a clinic because we would have a psychiatrist that would come once a week. And so that really was something that, thank goodness that we had that still, because we were still able to get our clients to see Dr. Hobart. But what happened for us with meetings and educating ourselves, what we had to learn, and I have to be totally honest with this, once we started probably, between 65 and 90 days after the pandemic hit, we started our groups. And what happened is we were not comfortable. There was staff that were not comfortable with coming back in the office. I was one of those people, but what I realized is somebody's going to have to sacrifice and allow ourselves an opportunity to have some kind of a group. And so I took that as a challenge and started our first group, the recovery process. And I have to tell you, early on, we had clients that let me know, like, hey, your Zoom skills are lacking. And so it was kind of fun, but I took it to heart because I wanted the clients, because of some of our clients were doing so well with like their recovery and going to meetings online already. I had to take it on as a personal challenge and educate myself on Zoom. And so I did that the next week, and nice. I got the accolades from my client, but it was getting over the fear, knowing how things changed, but how can we engage our clients and how can we make them feel safe enough to come to groups? So phone conversations, I think, were very, very big for us. And then that slow, gradual process. We are not at the place of going back for us at the Imani Center as of yet right now. So we are doing one-on-ones over the phone with telehealth in groups like that virtually.
Yeah, it's been fascinating, all the new technology that we've had to learn. I know it's been hard for me as a primary care provider, switching phone visits, video visits, having them interspersed in my day sometimes. And it's a whole new challenge. It's been fascinating to see the ways in which we've had these unexpected benefits. I think we've all become more flexible, and I've, given up the illusion that we can predict what's going to happen because we just don't know. It's been fascinating talking with my behavioral health colleagues, with you, with many others, and preparing for this presentation and just living through the last year. We've identified several unexpected benefits of the changes that the pandemic has inspired. For example, as we've mentioned, we now have better access to care through phone and video, folks who couldn't physically come in, folks who may be more vulnerable during a phone visit. Many of us have noticed that phone visits can be different. And sometimes, as I think Dave mentioned earlier, sometimes they're more open. People are more open when they're on the phone, perhaps when they don't have to face someone. As I mentioned, our teams have adjusted to change as a constant, and there's a new sense of flexibility and responsiveness. I think we as a community have an easier time talking about anxiety and other mental illness. When I work as a substance use provider, when I call clients, I can easily say, this has been a really tough time. Many of us are feeling anxious. How are you doing? So it just opens up a door to those conversations that was harder before. I'm curious to hear about any unexpected benefits that you've identified that have resulted from the COVID pandemic.
Yeah, I have to say a lot of blessings and benefits that happened for us at the Imani Center is, first of all, us being able to collectively engage as many clients and getting them to a place of feeling safe, but also allowing that space for them to get the specific services that they needed, because we have dually diagnosed clients, we have clients that are just on the substance use scale. So once we were able to adapt, the love that I have and the benefits that I think we created, like you alluded to, Elwin, is the phone conversations have been huge. I think it allows clients to be vulnerable. I think it allows us the space to really connect with them deeply. But I also believe that the telehealth one-on-ones have been impactful as well. But me personally, I love the phone, but the impact for me, which has been huge because I'm still learning, has been for groups, virtual groups, learning how to do these groups and engage the clients just as if I was in there in person. But what I've learned is I can show videos, we can still do our meditation, but understanding, taking each client through their own process, but allowing them that space and group to let us know when they check in how they're feeling, because that's a very big thing. And them to have the safety enough to share in group. That's not an easy task, but that has been a blessing and a benefit for us.
Thank you, Walter. I've so enjoyed talking with you, and just as happened before, I wish we could talk forever. And I just want to close with a reflection that there are benefits. It's been an incredibly hard time, and hopefully we can continue to show up for our clients and show them the love and the respect and the connection that they deserve. So thank you so much.
Thank you.
Thank you both so much, Eowyn and Walter. That was a fantastic conversation. Really appreciate it. It's just so great to sit in and like dig in. I feel like we're all together in the same room. I loved talking about the technology, bringing us closer, even while we're all getting over some of these unexpected learning curves. And so I really learned a lot from you. We are going to speaking of technologies, I've mute myself. We're going to turn to Laura Leone with the National Council for Behavioral Health, who's going to talk with us about wellness and resilience to support for those who are supporting individuals experiencing homelessness. And as we start, I am going to open up this second poll just to get a bit of a pulse check about self-care practices that you might have. So there's two questions here. How often do you intentionally practice self-care? So not at all, less than monthly, weekly, and daily. And the second question is, do you practice self-care for the specific purpose of preventing burnout? Yes, no, or not applicable. Awesome. Everybody is sticking with us in this webinar. It's perfect. So we've got just about half the participants have voted. We'll give a few more seconds before we close. So much great participation, and keep those questions coming. I know that we're not going to have a lot of time to get to all your questions, but we can and will follow up following the webinar as well. All right, so I'm going to give it the last 5, 4, 3, 2, 1. We'll end the polling. Let me share the results with everybody. So actually some good self-care practices here. So Laura, I'm actually going to turn it over to you. I don't know if you're going to process through the poll questions and start your session.
Yeah, thank you so much, Jen, and hello, everyone. Welcome. I'm looking at the poll results, and I'm really, really happy to see the results as they are, with so many people really practicing daily, if not weekly, and over half of you with the intentional backing of really preventing burnout and knowing and doing something different. This really becomes about self-preservation in the work that we do in this field, in this industry, and really across many industries. I think as we explore today, I can't help but think of a quote actually from American singer, rapper, songwriter, and flutist Lizzo, who said self-care is so much more than just going to the spa, getting your nails done, or drinking mimosas because it's Sunday, right? Like, we really, really recognize more and more that this is really, again, that self-preservation and the necessary things that we have to do to care for ourselves so that we can care for others. Next slide, please. So, this really brings us to what really wellness and resilience is all about. So that capability of individuals to cope successfully in the face of significant change, adversity, or risk, right? Like, we can apply that to many things in our lives, but certainly we have seen this and faced this, certainly with the COVID-19 pandemic. And that resilience is that capacity can, needs, it's like they change over time. It's enhanced by protective factors by both yourself as an individual as well as the environment. So it's a skill that can be built, it can be learned, it can be changed and enhanced. And so, that essentially to adapt when faced with this adversity and with significant amounts of stress, and to find a way to heal yourself and to return to an equilibrium or find a new or better equilibrium. And I think it's important to note that everyone has capacity for resilience. Everyone has different levels, but you have the capacity and the ability to build that. Next slide. So certainly, thinking about the need for resilience and the need for self-care does fall sort of under this, the response to falling under this continuum of traumatic stress. And we won't talk about sort of individual trauma or really even spend too much time on each of these areas, but really focus on the why of what we need to do to build that self-care. So we know that, there is certainly a level of secondary trauma, there's compassion fatigue, and sort of under that is burnout and also secondary trauma. And sometimes we're experiencing systemic, both organizational and systemic trauma. So there's all these different levels. And, I think sometimes when we use the word trauma, people have a very specific understanding of what that word means. So think about it again as adverse experiences as well. If we go to the next slide, this is really, I think, important to kind of talk about these components and how much it really does impact the field in which you work with for housing insecurity and homelessness. And I do want to note that all this data actually predates the start of the COVID-19 pandemic. And I actually suspect that the rates would actually be higher here because of the pandemic, although we have seen sort of a silver lining and a sort of secondary gain is that there is much more awareness of mental health, mental health needs and an awareness of resilience and wellness. And so people are making shifts, and I think that's true when I see, again, the rates of the polls that you have all answered those questions, about a year ago doing webinars such as this, people were saying much lower rates of that self-care or that awareness of burnout and the need to do something different. So, within the field, we're seeing, many different higher rates of traumatic stress and compassion fatigue, secondary traumatic stress, and burnout. As you see here, these are just sample studies, and there's many that exist that really talk about that prevalence of PTSD symptoms and really like moderate to severe secondary traumatic stress and all of these other pieces. If we kind of look a little bit further into each of these, so if you go into the next slide. So secondary traumatic stress, this is a psychological phenomenon in which, the caregiver, all of us as people working in the field, providing services, we can experience many common feelings and symptoms that are associated with victimization. And it involves physical and emotional stress response to working in a highly traumatized population, which we do. So, some of these risk factors, of course, is, exposure to just individuals and how we're working with them and their experiences. Certainly the empathy that we provide and we give and that we use. And if we have our own past history of trauma, and sort of the level or extent to that resolution, it plays a role as risk factors for, getting secondary traumatic stress ourselves. If we move on to the next slide, compassion fatigue. This is really, so the definition here on the screen, is really, we see this much more, I think, impacting in this field of work. And the phrase compassion fatigue was actually first used, I think, in the early 1990s in reference to an experience of nurses with burnout. And so there's definitely a level of burnout that's factored into compassion fatigue, but really, it was noted, so being compassionate, right? So bearing the suffering of others has implications such as becoming preoccupied with those other individuals with their traumatization, their adverse experiences, which certainly can lead to compassion fatigue. And it's really that, again, state of tension or preoccupation with your clients, and then ultimately re-experiencing with them re-experiencing the traumatic events, and sort of how that factors and plays into what we perceive and how we are interpreting their traumatic events. It folds along with avoidance and numbing, and sometimes being persistently aroused when you're with an individual or client, just sort of as a reaction to their experiences. And compassion fatigued practitioners and staff, they continue to give themselves fully to their clients, but they often find it difficult to maintain that healthy balance of empathy and objectivity, and a reduced sense of maybe even personal accomplishment, which, so is something that which can lead to burnout. And so if we go into the next slide, the cycle of burnout certainly is characterized by emotional exhaustion, depersonalization, that reduced feeling of personal accomplishment that I mentioned before. And, while it can be work-related, burnout also develops as a result of just general occupational stress, and it can happen in various professions, and certainly your personal life and how that impacts, and your professional life certainly plays a role in it as well. And so, the reality of the work that we do is both exhilarating, but it's also stressful. I'm pretty sure there's not many of you that would be here that wouldn't agree that there's a level of stress that comes with the work that we do. And so, really thinking about how that exhaustion cycle from starting with being busy to then feeling maybe a little bit more beat down, and then ultimately moving towards burnout, excuse me, is sort of happening and always a threat to us. It's, we give ourselves fully to this work. We are committed to the work that we do, but in doing so, we make ourselves pretty susceptible to this cycle that can happen. And so, we have to strive and build, to the extent of our ability, different supports, again, on an individual level, as well as an organizational level and a systemic level, for what we can do to kind of offset this cycle. If we go on to the next slide, some of the things that we know pertain to why burnout happens include lack of support or high demands, not receiving regular feedback, and feedback that not only is, hopefully a good feedback that helps us to grow and find sort of growth potential, but feedback about the successful things that we're doing. And, we need a balance there. Also, if there's any role ambiguity, or like not being clear about your role or responsibilities, or not having resources, so thinking about all of these potential things that really threaten the ability to feel good and to not experience burnout. And again, as I mentioned stress before, if we move on to the next slide, all of us to some extent are always going to feel stress. Stress is a normal part of our response to life and to situations, but it's when that stress happens persistently, that it becomes chronic. That's when we know, and we can recognize that becomes a problem. So, when we're experiencing stress, this graphic shows what happens to an individual that's exposed to long-term stress. So on the far left, you see sort of a normal response to acute stress, where an individual's body, you feel the heightened stress, you have experienced of increased adrenaline and cortisol levels in your body, you come down from that, and you return to baseline. But for individuals over time who you have a delayed response in coming sort of down from that stress, so repeated stress that keeps your stress levels high, and repeated events that continue without doing things to decrease those levels, over time, it's a delay. And ultimately, we see sort of on the right-hand side, this blunted response where our body's reaction to stress changes, and those hormones continue to stay in our system, and we're not equipped to respond to that long-term chronic stress. So, this response impairs multiple body systems in time, and we see things like hypertension and diabetes and mental health concerns and increased anxiety happen over time when we're not managing it and when it's happening. If we don't do things to proactively bring down that stress level, we are susceptible to these, more severe physical responses that happen within our body. Next slide. And so I talked, some of those responses you see here, right, and we do have, there's the stress that we feel, again, on an individual level, but there's also that collective stress, right? And I think of the pandemic and, working among our colleagues and really just feeling that tension in the air. And we saw this especially at the beginning of the pandemic. Again, all those sort of, Kevin referenced, like, how, what are we going to do? How are we going to manage this? Am I going to get sick? All those things that were running through our heads, right? That increased that collective stress that people were experiencing in addition to individual levels. And the effects of that, again, I would say are probably more severe than some of the studies that I showed you. Whereas, some of these things around our levels of our hormone and our blood pressure and the impact on insulin and the psychological responses that we had. People were having increased rheumatoid arthritis, heart attack, stroke, other infectious diseases. So it's again, sort of the why behind we need to focus on this wellness and resilience. So, thinking through, you can go on to the next slide. So as we move through thinking about what we do and bring to the work, we do have our own traumatic histories, we have our own responses, and we do need to watch out for the warning signs. Next slide. So, and thinking about the worst in every situation, if you're somebody who never takes a vacation or even a break, if you're not somebody who even pauses to take a lunch, or you take it sort of at your desk or on the fly or in between, home visits, or, however you're kind of managing that, those all actually take a toll. Decreased social life and increased arguments with your family. All of these things are good warning signs that you may have to do something different for yourself. So what does that look like? So next slide. It is about figuring out how to shift some of the culture of the way in which you work as an individual, also the culture for your organization, perhaps, and how we look at what staff can do, as well as what we can do for clients and consumers, right? So baseline is, creating a compassionate culture for everyone. So thinking through, how do you do that? How do you build that resilience? How do you support one another? How do you talk about this in a routine way, and also just in an authentic and open and transparent way? I think all of that is really important. I think when we tend not to address or not to acknowledge the potential for burnout, the potential for compassion fatigue, especially, we do run the risk of just causing even more problems for ourselves. So really thinking about how we create that culture. Next slide. Think of this resilience piece, right? This compassion resilience as a reservoir of well-being that we pull and we draw upon, especially on difficult days and in difficult situations. It allows us to be present and effective in challenging situations, and help for things to go right. Really, again, pulling from that reservoir, that well. Without compassion resilience, you likely would not be in this field to begin with, or you might not still be caring. So there's a level of which you come to this field with some compassion resilience, and again, remembering and encouraging that. And the demands and the pressure of our field can certainly serve as a drain on one's compassion resilience if we do not regularly act or refill that reservoir. So we all have our own ways of doing that and filling it. And so, let's think about just how we can make the most helpful choices for our well-being. Next slide. Excuse me. So, we saw a really great slide. Dave showed a really great slide on resilience and building resilience and sort of all the components there, which, I loved. I think definitely want to look at that and reflect on that information again. I think, building that resilience is breaking down sort of into these 4 components. And I would preface this that, I have expectations and boundary settings, kind of culture, and then self-care is sort of like the active response of actually doing the self-care. All of this, I think, falls under self-care. It is compassion resilience is an approach to building that resilience and really acknowledging and supporting concern for others and their well-being while recognizing the toll that a compassionate approach can take. It's, we want to build on empathy and the idea to successfully help and support others, and to feel, with another person and communicate that feeling to them. Going beyond just feeling with another person is the desire to diminish or eliminate their distress. So compassionate feelings for people, their family is to really think about, why people might begin to feel hopeless and really figuring out how to address that, right, when we're helping others. The same goes for ourselves when we think about these pieces, is really checking in with ourselves and figuring out, do I need to make a shift or change in, the expectations that I have for myself and what I think or perceive other people expect of me. Do I need to shift or change the boundaries that I have? Setting and maintaining healthy personal as well as professional and system-wide boundaries is a way to really take care of ourselves. And there's a way to have boundaries or to have those lines without having to feel like you have to do it in a rude way or a negative way, but just really exploring that and recognizing for yourself what makes the most sense. And I'll talk about boundaries a little bit more in a minute. Thinking about that you embed this in all aspects of your work. So, if we're talking about this with clients and trying to help them with their own way of resilience and self-care, trying to do it for ourselves is equally as important. Number one, it's a way to really practice what we preach and to figure out what works for us and to use those examples, that life experience, to share that with our clients. We might not be great at it, right? And that's okay. And I think it's okay to talk about that with our clients because it's real and it's an experience that is shared with others. And I think we can learn together as we work through that. And just figuring out how you do kind of practice that self-care, both at work or during work time and outside of it in your personal life. So really thinking through. If we go into the next slide, I do really encourage within the field, if you have the opportunity for any kind of supervision or check-in with a supervisor, a colleague, right, a peer, right? Supervision looks very different in different fields or under different professions, but some aspect of supervision for yourself, even if, again, it's with like a colleague or a friend or a peer, is really useful to processing the work that we do. Again, this helps with burnout. This helps really, helps us to help our patients or our clients with their own needs. And really built into that time frame, if you have any sort of formal supervision, about 20% of the time, I really encourage people to focus on self-care as a part of that conversation. Certainly we have the opportunity to talk about client cases during that time, maybe some clinical task management, so some of the administrative or some of the other needs that come up in our work that may be not particularly specific to a patient, right? All of that, we need to have that time to process, and that helps with burnout and compassion fatigue. It's a part of self-care. Next slide. I mentioned boundaries. So, creating these healthy boundaries, right? So understanding, expectations leads to creating boundaries, which are an important part of that culture of compassion. You know, this is really thinking through about sort of behaviors and attitudes that fit usually into 3 categories. So either lack of involvement, important to the mission, and the well-being or over involvement within sort of your work setting, and sort of thinking through those 3 areas and seeing where you fall in those 3 areas. So not everyone's going to have the same priorities or even ideas about what is helpful or sort of what level of involvement you should have, but discussions around boundaries and your own internal, thinking about it is really important to figuring out sort of what to do. And so things like knowing when you want to say yes versus when you need to say no, or being able to be proactive and having meetings around setting up structures or boundaries, or if you're going to make any changes to that, really helps people to pivot with you. Sometimes when we make these changes for ourselves, if we're not articulating that and talking about it with the people around us, they're often taken aback or surprised by it because we haven't sort of verbalized that. So really thinking about if you're going to make some shifts in how you do things or when you do things, or just any of the other boundaries that you keep, that you communicate that. I think figuring out as part of your workday, especially in the pandemic, a lot of us had to move towards virtual work, and even thinking about the boundaries of what our workday looks like at home. That's important to really explore, right? How do we figure out when we need to walk away from our workday, right? Like, what time is that? Is it at a specific time? If you're living in a studio space and your coffee table is both like your dining room table, the place where you relax to watch TV, and also where you put your laptop to do your work, is sort of your office, it's really hard to remove yourself from that space. So how do you make shifts or changes? Little things like sometimes people would put tablecloths or like a sheet over their space or pile of work so they wouldn't visually see it when they walk by. Things that we can do to kind of address and think through even sort of the boundaries that we need to put in place working virtually. Next slide. Building and figuring out what self-care looks like to you is important. So thinking about, again, checking in on that awareness, that balance, that connection, of what your needs are, and then figuring out how to create a plan for it. Next slide. We often work with our clients. We help them to create service plans, care plans, treatment plans, and why wouldn't we do this for ourselves too, right? So, whether we're just kind of thinking about it verbally, or if we actually write it down or put it in our phones or in some other digital way, I really encourage, thinking through that and creating that and being mindful of it, figuring out what works for you and what doesn't, and then practicing and figuring out what's on your self-care plan or not. So as I talk through some common ways that people will, provide relaxation and self-care to themselves, they don't work for everything, doesn't work for everyone. So really figuring out and practicing before you truly need it is an important piece. And then if we go into the next slide, there's all sorts of models that exist for self-care plans. One is the compassion model of wellness. You can find this actually as part of the Compassion Resilience Toolkit, which is a really great resource. I definitely encourage you to check it out. There's also the ProQual, and if we go into the next slide, this stands for the Professional Quality of Life Elements. And this is a tool basically to help understand the impact of trauma on the caregiver. This kind of helps you gauge where you are in compassion fatigue, burnout, secondary trauma, and then what your level of compassion satisfaction is. It's a really great tool and resource for gauging that, as is the Provider Resilience app. If we go into the next slide, and actually this app includes the ProQual in it. And I don't work for any of these people, but I definitely recommend as an application. This is another kind of great way that people have been able to monitor their levels of burnout and compassion fatigue, and then figuring out what to do for that self-care. And I think it's built for, I believe, originally professionals in Veterans Affairs, but it has been kind of used more universally in all sorts of fields for all sorts of different service providers. So definitely encourage you to check it out. Next slide. We also know there's other specific interventions here. So, we know things like, well, I'll just continue on with the next slide and I'll kind of cover these actually. So we'll go into the next slide. So improve nutrition, right? So thinking about just what we eat, when we eat, how we eat it, we know this, that this impacts how we feel, how we think, how we act. And at a very basic level, even changing how you snack could be, an act of self-care when you think about just like how you feel and how you take care of yourself. Again, like Liza said, it's not just getting your nails done. It could be just about how you eat things differently. Next slide. It may be also how you move your body differently. Thinking about, whether you take a walk around the room you work in, or, some of you have gotten standing desks. I think, some of you that are on today, or taking calls where they walk outside, or, just different things that we can do to move our bodies. And especially during COVID, where we've been sitting around and inside a lot more than usual, I think this has been something that people have really gotten to be creative in how they do this. Next slide. How we sleep is also, of course, important in figuring out that sleep hygiene, right? So that's the practice that you put into place for how you figure out when to go to sleep, stay asleep, things that you do leading up to that, all play a role. Whether you use your phones or you leave your TV on it or a radio on at night, all of that actually interrupts your sleep. And so there's really important connections between memory and cognitive function and mood that all can play a role in just us being, 100% for the workday. Next slide. And getting into some different techniques. So there are self-soothing techniques that we can do. And feel free to check out these slides, which these have a little bit more detail in them. If you go on to the next slide, there's grounding exercises, things when we're really amped up, things that we can do pretty quickly to kind of calm down, stay focused, stay connected. And then some more technical things like breathing, diaphragmatic breathing. There's all sorts of other kinds of breathing, alternate nostril breathing, meditative breathing. The next slide shows there's square breathing. Learning these different techniques, again, for yourself, again, to share for your clients, will help you figure out what to manage in your day. And I do really encourage you, practice it when you don't need it. See if it works for you, see what you like. If you go into the next slide, guided imagery, or sometimes called visualization, is really, again, putting yourself in sort of that mental rehearsal of being somewhere else and sort of transported, really thinking about using your imagination to really help you to feel and get relaxed. And then the last slide here that I'll move on to is progressive muscle relaxation. So really figuring out how we tense and then release the muscle groups in our body, and how we actually will enhance the reduction of the stress that we actually feel physically in our body when we do that. There's all sorts of everyday ways to relax. People take showers, they take baths, they play sports, there's all sorts of different things. Again, figure out what that is for you, and create it, make a list for yourself and practice that as part of your self-care plan. Hopefully from this talk, you can figure out sort of the differences between these concerns, the impact that you can have both on your personal and professional life by making some changes, figuring out ways to incorporate, and I really encourage you to just consider next steps that you can take. So thank you so much. I really appreciate your time, and I'll turn it over to you, Jen.
Great. Thank you so much, Laura. There is so much that we can all learn about self-care, especially about the practicing part of it. That is something I took away, practice when you don't need it. We are coming to the end of our time together. I want to honor and acknowledge the fantastic questions in the Q&A box. My commitment to you, the group here, is that we're gonna take a look at those. I'll work with all of our fabulous panelists to get some answers. We'll get an FAQ doc on the website and make sure that we're taking time to thoughtfully happily answer them in more than the 20 seconds we have left. The link to the evaluation is here for your certificate of participation, and just hope that you join me where you're at and giving a hearty round of applause and thank you so much to Kevin, Dave, Aowen, Walter, and Laura for this phenomenal information. We will post a recording shortly with a transcript. I know that I think I'll want to watch it a few more times to make sure I'm picking up all of the tips, because there was so much valuable information there. So thank you again to everybody for joining us, and I hope you have a wonderful rest of your day and week. Thank you so much.